wanted to invite you guys to like us on Facebook, especially since we're posting a video of the presentation, and to be the first person to follow us on Twitter, because no one has yet. The second person to follow us on Twitter. Wanted to post you guys for next meeting to come up with t-shirt ideas. There'll be an email about it. General interest in getting a t-shirt together for the microclub. So just whenever. Please feel free, if you've just moved in, to grab pizza. We don't really want to be walking in and up while Dr. Anderson's giving his presentation. And, so upcoming events on October 23rd. We are going to try to have that fundraising event that maybe a few who've been interested, we've talked to you guys about this before. It's a fundraising event for the Bill and Melinda Gates Foundation. We're going to be trying to sell baked goods. It'll be 10 p.m. till 1 p.m. Up on Felday. It's 1 a.m. Sorry, Felday Gates. So cool. That seems to be everything in the foreseeable future. Thank you so much. Defer to you, Mr. Ryan. Mr. Anderson?
Not doctor yet. Like John just said, I'm Ryan, exec board member for Microclub, and I'm here to introduce our speaker. He is from the Centers of Disease Control and Prevention, more specifically from the National Institute of Occupational Safety and Health, or NIOSH, the Cincinnati location. He's also my dad, so please welcome Dr. Vern Anderson.
Thank you very much. It was very much a pleasure when he asked me. I was actually supposed to be here last week, but I really had a pretty bad cold. Still got a little bit of it, but I think it'll be okay. The real purpose here, I'll sort of get to that too, but I really want to tell you about Centers for Disease Control and what a great place it is. And for people who are interested in health, I hope you young people look very seriously if you're going into any field. It doesn't matter, and we'll talk about that. But I'm really a marketing person right now for the Centers for Disease Control. I've been there a few years. I've seen a lot of great things. I've traveled all over the world, and you can't. And I met people, and I've seen some pretty sad situations, but all in all, it makes you feel like your life is worthwhile because you are trying to do something for people. So with that, yes, this is here.
Use the space bar.
There we go. Yes, Wisconsin and Madison. Some wonderful years with school, but interestingly enough, they do not have a school of public health. So you might say, how did I, who went to Wisconsin, get into CDC without going through a school of public health? And I don't know, but it shows you can do anything if you're in the right place at the right time and properly prepared. Okay, public health advisor, that's my title. I'm a senior research psychologist, and as Ryan said, I'm located in Cincinnati at the occupational arm of CDC. CDC has a lot of different group centers, and you'll see that in a little while. Okay, everyone always say needs a philosophy to get them up each morning, or simply I ask the question, why do I do what I do? It's been a lifelong search, and I take it very seriously. From the time I was a little kid, I always was very interested in what, oh, this is going to be fun. Okay. Hey. Oh, what's on?
You can use the space bar now.
Now I'll use the space bar. Right? That's better. Thank you. Well, my interest is why do people do what they do? Because actually so much of what goes on in the Center for Disease Control is about behavior. Human behavior and disease and health. So as a psychologist, that's actually worked out pretty well. That's why I became a psychologist, to learn, and I'm still puzzled so much by why people do what they do when they supposedly know information, and you think sometimes, you know, that they're not thinking clearly, but it's a puzzle that I will continue to be focusing on. And I think each one of you probably has a reason in your own life why you're doing what you're doing right now and what what the outcome is going to be. Okay, the outline of the presentation, real briefly, I'm going to talk a little bit about what I did, some of my experiences. It shows you the range of things you can do. That's another good thing about the Centers for Disease Control. You don't get stuck in one area. You can move around. They move you to different things, so you're always learning something new. And I'll also talk a little bit about how CDC relates to the federal government. We're talking about its mission, some of its strategies, and we've got a video that's done by CDC on Ebola. We're going to have a little case study here and talk about Ebola and what CDC has done with regard to Ebola. And this is pretty amazing and it's pretty heart-wrenching. And then the careers of public health, CDC, and sort of the inside path to getting the CDC schools of public health, and ERCs. That's another new acronym for you, Educational Resource Centers, and that relates a lot to the occupational part of it, and work life, impacting work life, like stress. One of the things I work been involved in is the effects of stress on a person's health, on the ability to work. In fact, the work does provide stress in a positive way and a negative way. So, we're going to have some questions, and okay, let's start off here. I did a number of different things. I started out, and this is not too far, we were interested in the effects of chemicals in the workplace, like organic solvents. How does organic solvent affect the brain and response time and decision making? Very interesting. Solvents are anesthetics. You can get high on them, and many people have. You can also kill yourself. Then there's something called human factors, which is really the relationship between your body and your equipment that you use. We did some work for the Navy on developing their cockpit layout, and it was all had to do with their behavior, their natural tendencies, and where things would be in that cockpit for them to be able to handle in cases where there was stress and they had to be such that was response was almost automatic. Psychophysics. People know what psychophysics is about? If you do, just raise your hand. No? Oh, come on. Psychophysics is very important. It goes back to some of the great philosophers. It has to do with the relationship between physical stimuli in the world and how you perceive it. You think about it, we never perceive anything exactly the same way as someone else. So psychophysics is learning about your view of what the physical stimuli may be. And it could be like a tone, which would be very simple, or it could be an experience where someone is in a car crash or you're witnessing a robbery or something. All that stimuli, and then your particular vision of it. What is it, your response to it? It's really exciting field, and it's part of psychology. We were interested in doing psychophysics when we were I was very interested in finding out at one time real quickly how much a person could lift safely. So we used psychophysics. We gave different types of containers and asked them to lift it and told them to adjust the weight of the container, because there were things you could adjust it to a level that they could lift it comfortably all day. So what we were doing is basically using a psychophysical approach for them to set up the stimuli so that their response was a safe one. It's very handy when you're dealing with issues of threshold and limits as to what people can do. And ergonomics, engineering controls, NIOSH is manual material handling, dealing with lifting. That's been a large part of my career. Also dealing with communications, and for a while I managed the NIOSH website. And we also I was engaged in doing a lot of research on customer satisfaction. Because one of the things that comes up is your bosses want to know how well you're doing and what people think of this program. So we had to go out to our audience, our stakeholders, and give them a questionnaire, survey to find out what we were doing right, what we were doing wrong, what types of publications that they liked, how they like to be, how they like information to be presented to them. Do they want a web? Do they like tweets? Do they, want Facebook? So there are a lot of systems that are in place now for people to get information, and that's sort of what we were doing there. Okay, surveillance, scientific writing. You're going to do a lot of writing. If you work at CDC, writing is a skill you'll do, particularly more and more as you get into your field. And enjoy writing, embrace it. It's very important. So that's what I did. Your life will be probably totally different. Okay, this is actually sort of a nice, it's a slogan. Got to have a slogan, CDC, 24/7, saving lives, protecting people. Very important to see saving money through prevention. And one of the things that people wonder when you hear about a big organization is, where is it in the government? Well, does anyone know where CDC is in the government? Where it's located? Which department? Department of Health and Human Services. Quickly, I'll show you this. I used to tell people, if I wanted to impress them, I was 4 steps away from the president. I worked at CDC, and that CDC is part of PHS, which is Public Health Service, which is part of Department of Health and Human Services. That's the president, and then there's 14 other departments. You name a Department of Interior, Department of Labor, I bet we could probably name them all. And then the other groups within DHHS are the National Institutes of Health. If you get your PhD and you become one of the best scientific investigators, that's a good place to work. It's in Washington area, FDA, you know what that's about. CDC, there's 7 different centers in CDC, and I mentioned I worked in the occupational one, the one that deals with work life and health. Okay, what is the mission? Very simply, it's detecting and responding. Those 2 words are really, there's a lot of information in them, because trying to detect something is much like, well, you might think of it as being a detective. And in a way, you do much of that early on in learning about diseases, because you're going to go out into the community. You're going to talk to people. And then responding. How, once you learn about the disease, what is your response going to be? What are the interventions? What are the communications that you're going to have to provide to deal with these health threats? So that's one of the key items. There's just a couple more. Also, tackling the biggest health problem causing death and disability. Who would like to venture and tell me what the #1 health problem is in this country? Yes?
Heart disease.
Okay, I can find a top 10 list where that's on top, but not in the CDC. But that's a good one. I mean, that was good. Anybody else? What's the top health problem in this country that we're facing? Obesity. Not around here. This place here, it's lovely to see everybody in such good shape. But obesity is the #1 health problem, because it does relate to heart disease, diabetes, and even cancer. So there's a condition. Interestingly enough, it replaces smoking as the #1 health problem. And just to give you an idea, I went to a couple of the more well-known sites to look at what were the top ones. And the cancer, as I said, heart disease, cancer, stroke, respiratory disease, injuries, diabetes, Alzheimer, influenza, kidney disease, and septicemia. Lovely disease from bacteria. Women are often infected by it. I think the guy that was a puppeteer who ran the Muppets died from septicemia. No poison. From bacteria. Anyway, it is. It's a big. But those are some of the top health problems. Our job is to, yes, focus our resources where we are dealing with the largest number of people that are at risk, and also the biggest, how severe it is. And when death is the endpoint, all of these are pretty severe. Okay, the third element is promoting health and safe behaviors in the communities and environment. So you can be working at CDC and your job would be to develop slogans or messages, program. How would we, let's say we want to develop and promote healthy and safe behaviors regarding to eating proper foods, nutrition, or something, you know, avoiding types of chemicals and things that could cause cancer, which is a big thing in the workplace, particularly when they use to paint automobiles. So that's they're promoting health and safe behavior. See, that's a little different than detecting and responding, because that's where you're out in the field and then tackling the biggest health problem. That's where you're looking at all the data and deciding where we're going to put our resources, and then promoting health and safe behaviors. That you do sort of in your offices, but you find out what are the messages and how do we reach these people. Developing leaders and training the public health workforce. So that's another reason for CDC, is we are actually trying to train people like yourselves in dealing with public health problems. So there's a lot of opportunity. When I came into CDC, I really was not that well trained in public health. As I mentioned, University of Wisconsin actually is not a school of public health. You'll see that. But I had other things going for me, I guess. So the training and also dealing with not just leaders and training, but working in communities. Community action is a very big thing. Obama was doing that early on, getting people, you know, at the community level to, you know, participate in healthy things and vote, that type of thing. Taking the health pulse of our nation. What that is all about is not going door to door saying, may I have your wrist, please? It's mostly about keeping track of changes in health. Because like we have influenza, every year there's different strains. Knowing, you know, what is having the greatest impact. So basically CDC is always monitoring. We do survey work, we do a lot of monitoring. The states provide us information about health outcomes, about fatalities, about major groups of injuries. Yes, another thing that obviously is dealing with right now, violence. Violence, you know, in schools, violence in the communities. That's a big problem right now for CDC. It's one of those things that we're trying to figure out what's the solution. There are a lot of things we can do. I don't know if there's one solution, but that is a type of example. The public health approach. See, I took some antihistamines. You know what happens if you take antihistamines? Keeps my nose from running, but it also makes me thirsty. So that's excuse me. When I talk about the public health approach, does anyone know what I'm talking about? Really talking about four, maybe five things. Very simple things. The public health approach, first thing you've got to do when you're taking the public health approach is getting data and information. Collecting data and information. It's called surveillance. And then following surveillance, you're going to do epidemiology. I wanted to be dramatic. I know someone loses it when I'm doing it. But so the number one thing in the public health approach is to start with collecting data. It's surveillance work. You can go to different types of databases. Bureau of Labor Statistics has a lot of good data that I use in the occupational world to find out where the injuries are, what businesses, what industries would have the most injuries and fatalities. So we use various workers' compensation records are very good. But in epidemiology, that's probably the #1 program of training that you will be taking or have taken prior to working at CDC. I should stop and say, you know, a lot of things that I'm going to be telling you sounds like, oh gosh, it's going to be a big job if I want to do this. What's neat about it is they hire a lot of people with minimal real qualifications, but you get opportunities for training in CDC. You can go in there with a bachelor's degree at a GS3 or 4 and have an opportunity to get a PhD. That's called long-term training. If you work for 3-4 years and you can apply for long-term training at some university, and they will pay you to go to school as well as your salary. The only thing you have to do is stay around for 4 or 5 years to make up for those years that you're been paid. So this is one of the things that I tell people. If you're not sure where the money is going to come from, you can look and take a very introductory baseline bachelor's level, which is usually as small as salary is, you know, would probably be equivalent to about $35,000 a year, between 25 and 35 to start with. But the opportunities, they have training courses. There will be offering courses during the day on these topics, and you just sign up for them and show up, and you'll have a 3-day class on epidemiology or biostatistics. And that's pretty nice, because you've got a job, you're getting paid for it, you're getting this education, and it's really valuable credits that will work and help you get a higher degree. Unfortunately, I didn't take advantage of that. I came into CDC, I already had got my terminal degree. The next thing we do is very simple. It is dealing with studying the causes. You're doing research, either in the lab or in the field. Learning what are the hazards, what are the agents, what are the viruses, what are the causes of your death or your disease that you're concerned with. So you start collecting data, you use epidemiology to try to pull out the risk factors. Then you go to research on causes. You look at those causes and try to determine at what levels they are critical, how many are different causes, usually are multiple causes, how are they related, and that's very important. Then, let's say you're successful and you found out something about the cause of this illness or disease you're studying. Then you're at a point where you can do something. You can intervene. You know, you've been collecting data, you've studied in the laboratory or in the field. You have an idea of when you know, by the way, when you know the cause, you pretty well know the solution, don't you? Take away the cause, whatever it might be. Control the cause. Neutralize it. But, you know, find a vaccine. So once you learn the cause, you have an opportunity to change things. You can your interventions is what we always call them. You're implementing these interventions, and there could be multiple types of interventions, but it's pretty exciting when you do learn, and it's not generally, you know, it's easier than you think. Once you learn about the causes, you just start figuring out, how am I going to control these causes, these risk factors? It's another name for causes. How do I control these risk factors? You know, it's human behavior, largely, that's going on here. People do certain things, which increases their risk. So a lot of the causes relate to human behavior, and as I said, that's a really important thing to understand. Okay, then you do your communication, your dissemination. You got to tell the world about what you've done. So there's a lot of efforts in figuring out how do we craft a message that is appropriate for that audience, that targeted group. Because in here you need to understand, that's where sociology is important, and cultural anthropology. Knowing the audience and the group that's you're studying that is at risk for this disease. So how do I communicate to that group? You know, understanding their needs. So you really got to know a lot about the audience, the population at risk. When you're developing your communication message and then you're disseminating, what's the best way to disseminate it? You know, you think of different things you can do, from television ads to, you know, the internet. Okay, and then once you do that, you learn some lessons and you may have to repeat the process. And your whole career can be going through those steps continuously. And it can be pretty exciting when you actually find causes and make a difference. Okay, CDC in the 21st century. We are very interested in technology, large data sets. We work with very large data sets to try to find out, again, the cause factors. When you have people from a certain segment of the society all showing these types of injury or illness, you need to be able to depend upon the technology that exists. And one of the things that's been really interesting is the work in predictive analytics. They use it for baseball to decide, you know, and football figures out tendencies and which plays to use. Well, CDC uses it in a similar way. Find out which approach might be best. And then putting science into action by tracking disease and finding out what is making people sick, and what's, again, the most effective way to prevent it. A little bit of repetition there, but that's the theme of what we're doing. Okay, finally, we develop new knowledge. This is developing new knowledge. I mean, you do research to try to understand what's going on about people and illness and also positive health qualities. We're now looking a lot at what are the things that make one community or one group of people particularly healthy. What is it unique about them that they live to, you know, long old age and they have minimal diseases? So we're always trying to not just examine the illness in our population, but also the healthy, the survivors, you might say. But we're always looking for that, and that's why it's a research environment. Sure, we have well-trained and well-resourced. This is what CDC is trying to do in our 21st century. These are some of our things that we want to do. Saving lives, protecting people. This is some, again, this is a little publicity. We're sort of patting our back. Our disease detection network responded to 535 diseases, detected 51 new pathogens in 2006. I mean, CDC has done a lot of neat things even recently. You can see some of that from themselves, and if you like your microbiology, there you'll see a plate and various people out there with personal protective gear. Doesn't show up real well here because of the lighting, but that's why we use long pictures. Now, we are pretty much on time. I've got a 7-minute video called The Road to Zero, which is pretty good. I think we might, is there any way to cut this light at least, or a couple of lights? This is, and then if you have a little more time, the second one, the deadliest outbreak. I don't know which ones. Whatever it is. Okay. Oh, well, enable. I don't know what we need.
Hit the X in the corner.
Up here, let's get rid of it. Okay.
Yeah.
All right. Okay, here we go. Now, is there a volume on this thing? We have our computer turned up? Let's halt this thing too.
Let's see. Fiddle with it.
Yeah. It's a pretty, the Ebola situation it's the most horrible way to die of any disease I've ever seen. The death of the Ebola virus is, you'll learn a little bit about it, but it's
rapid, unprecedented. It is impossible to pick one word to adequately describe the Ebola epidemic. From its origins in Guinea early in the year, the Ebola virus caught the world off guard, moving swiftly to neighboring Liberia and Sierra Leone, claiming thousands of lives and requiring a massive global response to help bring it under control.
When we activated the EOC on July 9th of 2014, it was a horrific situation. We knew that it was going to get much, much worse, faster than we could respond. And whatever we did, whatever we threw at the epidemic, we couldn't turn it around.
Early on, we tried to, stick to the core principles of what we knew, that it was contact tracing, it was case identification, it was educating people about disease and educating contacts to come to healthcare settings for diagnosis or treatment should they become ill.
We are following the ambulance you see ahead, so that after these two cases are picked up, we can do some contact tracing.
Cases in West Africa escalated quickly, and Americans faced the harsh reality that infectious diseases are just a plane ride away.
Today, we are providing the information that an individual traveling from Liberia has been diagnosed with Ebola in the United States.
I remember looking at the results and thinking, this is, a very historical moment, the first imported case of Ebola in the United States.
In the fall of 2014, CDC set key programs into action. Airport officials began screening passengers from Ebola-affected countries, and those travelers were monitored for 21 days. Experts worked around the clock to help hospitals prepare to treat Ebola patients.
We have 5,000 hospitals in the United States, and so they're not all going to have the exact same personal protective equipment. So in the past, CDC would allow for some flexibility with regards to changes in local protocols. What we learned with Ebola is that we needed to be much more specific.
I knew that making this training really good could be an opportunity for us to regain some of the confidence that I feel like we had lost when those nurses got sick in Dallas. I could palpably feel the tension in the room begin to go away as I went through this talk and as we did this demonstration.
CDC sent their Ebola lab experts to Sierra Leone to help rapidly detect cases. This also lowered the chance of an infected patient showing up in the United States.
I think lab testing is critical in any outbreak response. It's very important to get the positive patients into a treatment center, but it's also just as important to get the negative patients out.
A major challenge was getting the cooperation from the West African community. People were afraid of Ebola and skeptical of the foreigners who had come to help.
We needed to understand what was driving the behaviors contributing to the outbreak, and then craft the right communication messages to change those behaviors, and then deliver them in a way that people could understand.
As we moved into 2015, there were signs of hope.
When you can actually see contacts being followed and patients being discharged as survivors from Ebola treatment units because they are coming in for early care, those are the things that you see that can actually give you some hope.
Ebola has been a devastating experience for many of us to see death so up close and personal, to see deaths that we couldn't prevent. We've made great progress, but we can't let down our guard. There will continue to be cases and clusters of Ebola, but an epidemic of the kind we've had for the past year never has to happen again.
Over. It is a word we can't use yet. The Ebola epidemic highlights the need for strong public health systems before outbreaks happen. CDC is establishing offices in Liberia, Sierra Leone, and Guinea to help them prevent future cases of Ebola and prepare for the next health crisis.
just sit the right axis and the right hand corner.
Is that here?
On the
Back
right
here,
hand
yeah.
corner.
Okay. There we go. There is yet another, let's, go from the first slide. And there's another, I think we have time, this is another 7-minute version that I think also is a little more vivid in some ways.
I've had it with my moderate to severe plaque psoriasis. The frustration, covering up. So I talked with my doctor. He prescribed Enbrel. Enbrel is clinically proven to provide clearer skin. Many people saw 75% clearance in 3 months, and Enbrel helped keep...
When it comes to Ebola, the first thing you need to know is that dying from the virus is like something out of a horror movie. It's extremely painful and terrifying. First you get a fever, then uncontrollable diarrhea, then you begin hemorrhaging blood. And while all that's hitting you, you lose touch with reality and become delirious. Finally, within days, you are dead. West Africa is currently in the midst of by far the worst case of the disease since it was first discovered in Africa back in 1976. This year's outbreak has been traced to a 2-year-old boy who died on December 6, 2013 in a village in Guinea. He probably got the virus by eating contaminated food that had been drooled or defecated on by a bat, or, as is common in this part of the world, had eaten some bat for dinner. Bats, researchers believe, are the carriers of the disease. As if the 2-year-old's death wasn't tragic enough, a week after it killed him, it killed his mother, his 3-year-old sister, and then his grandmother. Now, it's customary in some African villages to prepare a body for burial through the extremely sanitary cleansing ritual that involves evacuating the body of all food and excreta, often using just bare hands. Since the disease is spread by bodily fluids getting into the eyes, nose, or mouth, it's no surprise that 2 people who traveled to the grandmother's funeral caught Ebola and brought it home to their villages. After escaping Ground Zero, the highly contagious, undetected virus was off to the races. By the end of March, Ebola had reached Liberia, and in June, the first case was reported in Monrovia, Liberia's capital city. That's when outbreaks like this really start to spread, when the infected people make their way to population centers during the incubation phase, before their symptoms begin. A group of people from Sierra Leone who had traveled to an Ebola victim's funeral brought the disease back across the border, and in late July the virus had hit Sierra Leone's capital, Freetown. Guinea, Liberia, and Sierra Leone are 3 of the 17 nations that form the Economic Community of West African States, whose combined territory is roughly half the land area of the United States, but with a population roughly the same at 340 million, it's about twice as dense as America. And since the disease is easily passed from person to person, and there are lots of people here, it's crucial to get outbreaks like this under control as quickly as possible, especially since a staggering 47%, or 2,984 of the just over 6,400 people who have been sickened by this strain of Ebola have died. So understandably, this is terrifying to neighboring countries, who have responded by shutting down their borders. Still, Nigeria, the largest country in Africa by population and economic output, couldn't keep the disease beyond its borders when an infected Liberian-American man named Patrick Sawyer flew into Nigeria's largest city and died shortly thereafter. A Nigerian doctor named Stella Ameyo Adedeva stopped Sawyer from leaving the hospital, stopping the spread of Ebola to the 21 million people living in Lagos. Sadly, Dr. Adedeva contracted Ebola and died, but she left this world a hero by helping to successfully limit the outbreak to just 21 cases and 8 deaths in her country. No new cases have been reported in Nigeria in weeks. Liberia's experience, however, has been the exact opposite. The disease is out of control there. Cases doubled in the 3 weeks between August 31st and September 22nd. As a response, Liberia's Harvard-educated president, Nobel Peace Prize winner Ellen Johnson Sirleaf, the first female head of state in the history of Africa, had no choice but to order a lockdown of a highly infected slum in the capital. This didn't last long, though, as an angry crowd attacked an Ebola center and freed the infected. The second hardest hit country, Sierra Leone, has resorted to an unprecedented 3-day nationwide lockdown of its 6 million residents in an effort to halt the disease. But these countries are fighting an uphill battle. Many parts of West Africa lack even proper sanitation or drinking water. Too many people are poorly educated, scared, and mistrustful. To add insult to injury, aid workers keep getting attacked for spreading information about Ebola or trying to collect the bodies of the disease's victims. And in September, an entire team of 8 aid workers was murdered by villagers in Guinea. When American healthcare workers in Liberia contracted the disease and had to be flown to the United States for life-saving treatment, the rest of the world was shaken by the possibility of Ebola spreading outside of Africa's borders. It was the first time an Ebola-infected person had stepped foot on American soil. But it wasn't the first time someone on Western soil had been infected. In 1976, the year of the first documented Ebola outbreak, a British scientist named Geoffrey Platt, researching the disease in a lab in England, accidentally stabbed himself with a syringe containing the virus. As the unmistakable symptoms of Ebola set in over the next few days, the British government acted swiftly. Platt was transported in a special ambulance, under police escort, to a London hospital where he was the lone patient. He was kept in an isolation chamber, and all hospital staff working on his case were quarantined, as was his family and any lab workers and friends he had come in contact with. The extreme action worked. Platt recovered without infecting anyone else. But the current incarnation of Ebola is threatening to overwhelm the much more economically challenged West African region. Answering the call to action, the United States military is taking the lead in overseeing and coordinating the response to the epidemic. In addition to U.S. Centers for Disease Control and Prevention staff who have been there for weeks, President Obama has ordered 3,000 American troops to West Africa to build 17 100-bed treatment centers and a site capable of training 500 healthcare workers a week. The U.S. response is worth an estimated $750 million over the next 6 months. The Bill and Melinda Gates Foundation has alone donated $60 million, and the foundation of Paul Allen, Gates' co-founder of Microsoft, has given nearly $12 million. The American-led international response may come just in time, as infection levels were spiking exponentially in the middle of September. If no help had come, some experts were fearing the disease could have overwhelmed the region and spread until it exhausted its host population, killing hundreds of thousands or even millions of Africans, all the time increasing the odds that it could make its way off the continent. The World Health Organization now optimistically hopes to control Ebola by mid-2015, limiting the death toll to around 10,000. Thanks for watching this installment of the Daily Conversation. If you'd like us to tackle a particular subject in this mini-documentary format, leave your idea in a comment below. Until next time, I'm Bryce Beck.
Watch me fiddle around with it. We watch time. I'm going to give a pot of cup some plates. In that first video, we talked about what the core principles are, and the woman was talking about the science of surveillance, where you do contact tracking. You get out into the community and find out who has talked to someone else or touched someone else, and then you try to determine if it is a case or not a case. And then the next step is education. After you've sort of been out in the field, you've got to provide information about the disease, about where health care can be found, and what personal protective equipment. And also space suits, virtually. They were absolutely necessary. We know how Ebola is spread. It's not spread that easy, but it's highly infectious. It's spread through any contact with body fluids of any type, particularly if it gets into your mucous membrane. So anything from a tear and something like a sneeze, or from your mouth, from any aperture, it gets into your system. The eye seems to be the vehicle by which most people seem to contact the virus. Okay, whoops, I think I want to go back really quickly. Let's see here. I think I got back there. Yeah, am I going back? Yeah. Okay, I did jump ahead a little bit. Okay, we covered that. Now, this is simply knowing the numbers. You'll have it on your sheets and everything. I won't belabor it, but it does sort of tell you there's a lot of heat died, but the United States we've been pretty fortunate. Okay, careers in public health, academic preparation. I mentioned earlier on that an undergraduate degree is certainly you got to start with that. Although you can start even in your junior or senior year in working in some of these programs. For example, in our in NIOSH, we have people who come in for the summer who are juniors or seniors and maybe biology or statistics or even sociology, psychology, and they learn a little bit, make some money over the summer, and there's information about how that is done. It's not easy. But if you are in science and biology, you are going to be a prime candidate. But do not think poorly of the social sciences, because so much of disease isn't just about working with a microscope in a laboratory, but it is dealing with behavior. As I said, that's the big thing for me, learning why people are doing what they do. One of the interesting things about the Ebola behavior is the nature of the burial process. They want to squeeze all of the body fluids out of the body, and they do it manually. And with no protection. And when you have an Ebola virus, that is the most terrible way of spreading that virus in tremendous amounts. So certain behavioral and cultural practices can really aggravate and impact, and how you change behavior is the hardest thing. You can change and make interventions in science and make viruses and make vaccines like we did. There is a vaccine now that is working pretty well. But the hardest thing is changing people and what they do, and that's always the link that we struggle with. Math and statistics is a big part of it. If you're in language, Spanish is important. Economics and just any technology. Now, back to my model. If you got a bachelor's degree and you want to go and further and you have opportunity to go to graduate school, which usually means you have pretty good grades, you should try to get a master's in public health, MPH it's called. And that is very important, or very useful, not critical, but that is a good way to get attention and for employment. And certainly we all want to be out there in Africa and that tropical climate it is. But we have people from our division, actually 3 women have gone to Sierra Leone and been working there, who are one's has an industrial hygiene degree, and the other one actually is a librarian, believe it or not. So the optional science, you get a PhD in a science or social science, it's also a great way to come into CDC. There's one secret selection criteria that I think Brian knows this, and I told it to him a couple of times, how I got into graduate school and into the University of Wisconsin-Madison, a very good program in psychology at the time. I was in my junior year in college, and I decided to go start talking to people who ran the graduate programs. And I just made it a job to go around to different laboratories and to try to meet with the heads of graduate programs that I thought I was interested in. Well, I met this one professor, an old German guy, Carl U. Smith, who was somewhat eccentric, but he was using wonderful technology. And I love technology, and back then we were just starting with some of the computer stuff. But, he asked me one question, although later on he had to obviously get more from me. He says, take any math? I said, did you take calculus? I said, well, as a matter of fact, I ended up taking 2 semesters of calculus. And he said, well, you won't need it. But he said, what grade did you get in? So I got B. So he said, it's good. And why don't you sign up on these papers and we'll talk, we'll come back next week. And so the secret is, you take a tough course and get a decent grade, like a B. They look at that, and that sometimes is, I've seen more, I do it myself. Because I'm hiring people to work in, and I've hired probably about 50 people in my career already. And yeah, I often look down at the transcript. I'm not even interested in the total grade point average. I often look at the courses they've taken. If they've taken some really tough courses, I mean, you can certainly look at some of the chemistry courses, organic, analytical, and and physics, and math, and calculus is a good example. But for whatever reason, we all think in our little brains as we're trying to select candidates for graduate programs. And in our case, you couldn't get into graduate school unless you were getting funding. So they had about 10 scholarships. And so the deal was they selected you and gave you a scholarship, but if you didn't get a scholarship, you didn't get in. It's sort of strange, but that's how they did that for years. I don't know if they still do that. I doubt it. But the point was they just wanted you to focus on your work. And I was very lucky, trust me, I was very lucky. There have been 100 other people that were probably more qualified or better, but whatever it was, he said, yeah,